everyone. Welcome to the special edition of our Health Equity Jam session titled Achieving Health Equity Together, Local Lessons and Global Applications. I'm Yvonne Commodore-Mensah. I'm an assistant professor at the School of Nursing, and I'm honored that you're all here with us today. I'd like to acknowledge the presence of the Dean of our School of Public Health, Dean McKenzie, as well as the Dean of the School of Nursing, Dean Patricia Davidson. Thank you for coming. And I have one housekeeping item, which is that if you'd like to share reflections on today's event and you'd like to tweet, please use the hashtags local global learning and or health equity voices. And so with that, I'd like to start by introducing our panelists for today. So first we have Mr. Abdi Rehman. Abdi, he is a community organizer of Shanborough Community Association. He's a research assistant and community advisor for the research program on children and adversity at Boston College School of Social Work. And next to him, we have Dr. Teresa Betancourt. She is a Salem professor in global practice at Boston College School of Social Work. And she's the director of the research program on children and adversity. And then next to her, we have our dear Dr. Lisa Cooper, who is the director of the Center for Health Equity. She is a Bloomberg Distinguished Professor and a professor in the schools of medicine, public health, and nursing. And next to her, we have Dr. Olubenga Ogedegbe. I hope I got the pronunciation right. He is a professor of medicine and population health at New York University, as well as the Associate Vice Chancellor for Global Network Academic Planning. And he directs two centers. One is the Division of Health and Behavior, as well as the Center for Healthful Behavior Change. And last but not the least, we have the very Reverend Deborah Hickman. She is the president and CEO of Sisters Together and Reaching, STAR. And she's also the co-chair of the Johns Hopkins Center for Health Equity Community Advisory Board. So thank you all for being here today.
Thank you.
Before we start, I wanted us to take a moment of silence to remember the lives that were lost in Sri Lanka over the weekend. We all bleed the same, and so I'd like for us to take a minute to stand in solidarity and remember those who lost their lives and also remember their loved ones. Thank you. Please be seated. Okay, so before we start by introducing our panelists, I'd like to first frame our discussion for today. We know that health equity or health inequities cut across geographical and social boundaries, and the causes of these health inequities are complex. They range from health policies as well as unequal distribution of social determinants of health. And we also know that non-communicable diseases have become increasingly prevalent throughout the world, and many parts of sub-Saharan Africa are affected by non-communicable diseases. We know that 90% of premature deaths from NCDs or non-communicable diseases will occur in low and middle income countries. The good news is that the evidence-based strategies to address these NCDs are well established. And strategies to address mental health disorders such as depression and anxiety are also well known. However, the challenge is how to translate these evidence-based strategies equitably across the globe. So today, we are honored to have our panelists who are collectively doing work to achieve health equity locally and globally. So regardless of the hat that you wear, I hope that you walk away today with some energy, and we hope to spur you into action to use your unique talents and background to strive to address health equity locally and globally. So we'd first like to ask our first panelist, Mr. Abdi, and all of you actually, tell us a little bit about your background. Everyone has a story. How did you get interested in doing work to achieve health equity? And we'll start with Mr. Abdi.
Yeah, thank you. My name is Rehman Abdi. I'm okay if you call me Abdi. A few people always have a problem pronouncing my name too. So I started working with the Shambara community 2004. Shambara community is a Somali Bantu group that came from Somalia. The government started settling them 2004 because of they were in Somalia when the war broke down. They were minority in there, and they were used as when the war broke down, they were raped, they were looting, and then they didn't have they were considered as a second class citizen. So they moved to the refugee camp, and then in the refugee camp they applied. They came to the United States, so they had a lot of issue adapting with the system in here. So then when I moved to here, I knew a little bit about English, and then a few of us started stepping up to help the people who are struggling. So that's how I get involved with, we see a lot of issues happening with the community, and then we involve working with traces research. We find a lot of things that we step up to help with the community.
Thank you. Dr. Bettercourt.
Sure. So I grew up in what might be considered a low resource setting in the bush, Alaska. My father had been in the Peace Corps when it first started in Ethiopia and had wanted to continue to give back to communities that were underserved. So I was born in Bethel, Alaska, which at the time had about 3,000 people. Wow. No paved roads. We did not have plumbing growing up. And I grew up watching slides of my father's years in Ethiopia and was always very interested by other cultures. Having grown up in a different culture myself. And so I studied psychology. I went on to have a master's degree and do school-based mental health, and had worked with the Upward Bound program, where we were serving a lot of refugee children and adolescents, helping them be the first generations to go to college, and met Vietnamese, Laotian, Hmong refugees, and was really inspired by that. So I had an interest in migrant communities, and then went on in my direct service work to start to question whether or not we were just band-aiding a lot of problems by treating mental health disorders in children. What could we do on the prevention side? So instead of, as I had originally thought, going into clinical psychology, I went to study public health at the Harvard School of Public Health, where I studied psychiatric epidemiology, maternal child health. I had a period working at the United Nations in 1995, which was the year of the Grassa-Michel report on children in armed conflict. And this brought together NGOs working on children in armed conflict. The mental health and trauma topics were very present, but also the human rights orientation. And so I did my doctoral research looking at war-affected populations and learning about human development models, went on to do longitudinal research in Sierra Leone. From that, start to think about intervention models, and not only in sub-Saharan Africa, but also promoting mental health in other populations where children face adversity. And I met many members of the Shambara Association back in 2004 in Boston, and we'll tell you more of that story, but that's how our collaboration started in New England.
Great, we're happy to have you here today. Dr. Cooper.
Yes. So I was born in Liberia, West Africa, in Monrovia, Liberia, small country on the west coast. And my parents were professionals. My father was a surgeon there, and my parents operated a small hospital called the Cooper Clinic. So I got exposed to healthcare at an early age. I used to work there during the summers with my dad. And because I kind of had a pretty comfortable life, it was pretty apparent to me that not everybody around me had that same opportunity. So I saw a lot of children around me who were poor and who didn't go to as great a school as I went to. And I always felt that it was going to be important for me to do something to give back to my country. And then also my parents were involved in a lot of community service oriented activities. So I think early on I developed that orientation. Fast forward many years later, on my 17th birthday, there was a coup in Liberia, and a lot of people were killed, including close friends, parents. People were being raped. You know, it was a conflict situation. My family left Liberia and we came to the US, and I continued my education here, and then decided I was still going to become a physician because I always had that orientation early on, and did my training here always with the mindset that at some point I was going to go back to Africa to try to make a difference, but couldn't really go back to Liberia with the conflict continuing there. So I came to Baltimore after I finished my medical school training and did a residency here in Baltimore. And when I started working in Baltimore, I was just amazed at how similar the issues were here to what I had seen growing up. There was a lot of poverty. People weren't really able to afford their medications, or they didn't know everything they needed to do to stay healthy. They felt discriminated against when they went in for health care. And so I really became inspired to continue that work, you know, that I had originally planned to do, but not only thinking of it as being a problem that was only going on in Africa, but also realizing that it was going on here. So.
Thank you. Dr. Guillotine.
So my case is a bit similar to Lisa's, other than the war in Liberia. I'm from Nigeria originally. I was born and raised there, and I went to the former Soviet Union, Ukraine to be specific, for medical school training. I just want to be a doctor. In Nigeria, we say, who are you without what you do? So I'm the son of a clerk and a market woman. And so my mother was a market woman. I don't use the word illiterate. Illiterate means you can't read English or speak English.
Right.
She was a very intelligent market woman, not educated. But with that, my grandfather was the chief imam of a major area in Lagos, Ibutemeta. And so you grow up with all cadre of people with different socioeconomic status. My dad was a clerk, so that would be considered highly educated,
Right.
even though it was just middle school, to become a clerk in the British government. So with that, I went to the Soviet Union for medical school, trained in a place where healthcare wasn't a problem. People don't ask the questions, you know, do you have medications, do you have access? And then returned back home as a physician to practice in the government hospitals. At the time, in 1988 in Nigeria, our government had evolved a series of coups. So poverty was not always there because people could afford to eat and drink. But by 1988, it was becoming really obvious that we're having the middle class, if there was anything like that, had actually disappeared almost. So the government hospitals was where people who are poor who received their care. And I had a certain, shock that, you're coming from Russia where you didn't have any of that to a place where you're now seeing stark difference in the kind of care that people receive. And then I came here 28 years ago with my wife, girlfriend at the time, and did my training in internal medicine in the South Bronx, Montefiore Medical Center, and then went to Cornell for my fellowship in health services research, and then did my PhD at Columbia. So I'd been around, but when you practice in the South Bronx, you're living in Russia, health insurance, abundant, medicines, you can afford it. You go to Nigeria where you have class differences, and then you end up in the South Bronx, in the US where you felt like, everything is here. So in the late 80s, early 90s was the height of the HIV epidemic, where we had the whole floors of HIV patients. I got exposed to a lot of not just racial differences, but also class difference. So my interest in health equity research is largely based on that. And then like Lisa, I just wanted to go back. In our case, it was like when we had kids, and I really couldn't go back.
Right.
And I found myself at NYU 10 years ago. So NYU is a medical it's still a medical powerhouse in New York City, but also a global university. So we have campuses in about 12 countries in the world. So what I did was, I went with a team of faculty to Ghana. We have NYU Accra. And it was nurses, doctors, social work, Mary McKay, and a bunch of other folks from the business school and the law school. And it became very clear to me that capacity was a problem. So about 6 years ago, I evolved into looking at, most of the work I do here is purely disparities in hypertension care between blacks and whites. But how do you translate that globally to build research capacity? So hence my interest in both local work here in health equity, but also building capacity in low-income countries.
So Dr. Ogedibi said that his mom was very industrious. What he hasn't disclosed is that he just returned from Nigeria about a day ago and had to present at Grand Rounds, got on the flight here, and he's jet lagged, but you can't tell. So
my speech is not slurred yet. It's 4 p.m.
Thank you for being here. Reverend Hickman.
So, Reverend Deborah Hickman, better known as Debbie to my family, or Deborah if you're upset. And 64 years ago, I was born, 63 and a half years ago, I was born and bred at University of Maryland Hospital on the west side of Baltimore City. To Hattie Hickman and Johnny Hickman, who were not educated. They hailed from South Carolina, so I am third generation of sharecroppers that moved here from the South, that I witnessed going back down to see my grandmother, that slavery was alive and well during my era. And so from 1968 all the way up until about 1970, we went there every summer, the day after school closed, and we stayed there until the day before school opened when our parents came back to get us because they could not afford childcare. And so while there, we experienced still slavery was in full effect. I learned how to pick tobacco. I learned how to string tobacco. I learned how to pick cotton. I learned to take the abuse from someone else who had plenty. I'll never forget the day that my grandmom, my brother, and I had walked back from the barn to have what they call dinner, but we now call lunch. And just as we sat down to begin to share our meal, the owner of the land came and says, "We are planning, Miss Amanda, we're going to have dinner at our house tonight, so we need you and the children to go up to the water hole and pick us a pail of beans." A pail of beans was a round tub of beans. It's high noon, the sun is hot. And he put us on the back of the pickup truck. He gave my grandmother respect by putting her in the cab of the truck. But when we got up there was no shade at all. And I said out loud, "Why are we picking this man's beans when they've already eaten and we haven't, and we are hot, nothing to drink?" And my grandmother just went, "Wow," and I went flying. And he said, "Thank you, Miss Amanda," because I didn't want to have to hurt the girl. I really didn't want to have to hurt the girl. And my grandmother looked at me and said, "Don't open your mouth." At that point in time, I learned that I had a voice. And after I became 14 years of age, I never went back except to visit here and there and primarily to say farewell to loved ones that were moving on. We still have family there, and a lot of our family has moved north. But in coming here, as I grew up, I became a teenage mom. And it was Dr. Prasanna Nair and Dr. William Flowers who taught me that at the tender age of 15, giving birth, that I had moved into womanhood and I deserved to be respected. They went to the clinic with me to make certain that I understood how to navigate systems. They were of different cultures and the like. But at the time that I had my firstborn child, Dante Hickman, that they actually stood at my bedside and showed me how to nurture my child. And my mom had become an alcoholic. And so my interest grew out of the fact that what I witnessed in the hospital was that I was discriminated. I was not treated, nor was I in the same ward as other women were. And that if it had not been for Bill Flowers and Prasanna Nair, I would not have known what to do and how to do it. But Dr. Nair taught me how to be diplomatic and what I had to say and what I was feeling. As I grew further and to move fast forward things, as the HIV epidemic came upon us here in Baltimore City, there was HERO, but there were no spaces or places for African American women who were living with HIV or who had full-blown AIDS. I took it upon myself to get in touch with a doctor that I had been working for whose grant was coming to an end, to ask if I could actually continue to work in HIV and AIDS. At the time, I wasn't doing that particular work, but I got the job, and in getting that job, I found that there was so much discrimination against us as Black women. And the voice where you would go into a meeting and the doctors didn't want to hear what you had to say, but they wanted to hear what she had to say. Until one day I just had had enough, and my hand landed firmly on the table, not like this, but like with a crackling sound at the table. And I stood up and I said, Dr. Johnson, you listen to everybody that does not look like me and a few others of us in this room. And these are the people that we go out to service every day. You will not disrespect me. You will not silence my voice. The room got cold quiet. And in that moment, I realized that I shouldn't have to bang on the table, and I shouldn't have to feel like I'm going to be terminated today. But when the meeting was over, Dr. Johnson came in my office, and he says, what gave you the power to say what you said the way that you said it to me? I says, you released something in me that should not be in anybody's case. And so therefore, I felt as though I had to speak for myself because you are not speaking for me, and nor do you care about the women that we see in the Spice Clinic, their babies, the like. I says, you want to tell them what they should do based on your values, based on your culture. But we cannot do that. And you do not understand, while you call them non-compliant and the like, they're not non-compliant. You just are disrespecting their value system and our culture. And so to that end, my story goes on and on because he gave me respect. He apologized before his death. He asked me to come to his bedside. And from there, I grew into the self that God had purposed for me to be. And so when a lot of story I could tell you, but I would be really taking too much time. But I met Dr. Lisa Cooper 8 years ago, and I've been, as Dante Hickman would say, 10. Dante Hickman would say, high and happy and peacock proud, to find a physician that has a heart for the people and community, has not lost perspective, and believes in equity. And so that's how I arrive here today.
Thank you, Reverend Hickman. Every time I listen to her, I feel like I've just been taken to church. I don't know if you agree with me, but your comments are a great segue to the question I wanted to pose to our researchers. So how do you go about partnering with people in the community who are voiceless and are socioeconomically disadvantaged? How do you create these multidisciplinary partnerships to address the health of vulnerable populations? So, Dr. Bedden.
Sure.
Yeah.
Well, I think the first thing is finding a shared passion, a shared vision, a shared commitment. You have to both be in it. And then to really build partnerships and commit to them over the long haul. So with the Somali Bantu community, we've been collaborating since 2004 and have really persevered, behind all kinds of challenges, ups and downs, trying to get the right funding in place, and then also making sure our mechanisms for community involvement are serious and that we are also finding the win-win. So a lot of what we do, our work is always on this spectrum of community-based participatory research in some way. So we're looking to hire from the community and then all sorts of issues of how to do that thoughtfully. to build capacity so that we sort of see that we have things to offer in terms of what we know how to do, but we're certainly not the experts. And there's tremendous expertise in the community that we have to learn from. And it's really two-way learning as we see it. And we can't do good research without that sort of approach, that by having those partnerships, we can arrive at a level of understanding of community issues that's much more meaningful and in-depth. We can be more ethical and sensitive in how we conceptualize research, carry it out, and then also what we do with our findings.
Yeah.
What are the implications of once we have findings, how do we disseminate those? How are they used? Who owns them? That it's really shared ownership, and the community can use data that we've collected together for other purposes too, to raise awareness, for grants, for advocacy, in addition to us publishing and having research products from that. So that's been an important part of our work.
Great, thank you. Dr. Cooper.
Sure. I think a lot of our relationships with community have really come through personal connections. So what happens, I think, when you're at an academic institution such as this one is from time to time you get invitations to go out to community organizations and to speak about health or healthcare access issues, or maybe even about research findings. And the temptation is at times that, a lot of times it's after hours or it's on the weekend or something like that. And it can be difficult because it's not really part of what we get rewarded to do in academia. But the way I've actually built partnerships with community members is often through accepting those invitations and going to some of those events or those activities and giving up my time. So basically sharing what information and knowledge I have and trying to help people connect with the kinds of resources they're looking for, but then also just taking that opportunity to listen and learn from them about what's going on in their organization or within their neighborhood and try to figure out what's important to them. And by doing that, that gives me a better sense of how my research can be more relevant and more appropriate. So I think it's been a lot through those personal connections and like I said, taking the time to go and be there and not be here and expect people to come to me. So, that's been what I've done mostly here in Baltimore. I've done work in Ghana as well as in Liberia, and I would say the approach there is similar, but what's different there is that oftentimes I'm seen as an outsider because I don't live there and I'm not teaching or doing research there, on a regular basis or on a daily basis. So in that case, I usually rely on someone who is from there, someone who has connections with that community to actually introduce me to people and to show me the ropes, the right way to do things. So for example, maybe here it might be appropriate to just show up at an event and, to begin to talk to people. But, if you're in a community where you're not from, you are not expected to just show up and start talking. You have to be introduced to people, and people have to sort of tell others who you are and why you're there and legitimize your being there. And then there are just ways of doing things. So, for example, a community meeting might start with prayer, as opposed to, something else where you might just kind of go up and shake hands with people. So that's the way I've kind of gone about it, and really just use the opportunity to look, listen, and learn before, asking for anything.
I think we can all attest that, Dr. Cooper, you make it look so easy, and you are very generous with your time. So thank you for sharing that with us, Dr. Guillotine.
I think for me, my mother was a market woman, so which means when you're coming from school, you have to stop at the market store, say hello, and meet people. And so the way I think one builds that community relationship is respect. And I think Lisa said it well, that you've got to listen. In my case, in New York City, my residency training was in social medicine. So in social medicine, we had to go Remember in the South Bronx was the AIDS epidemic time. We had to do a lot of home visits. If you're not comfortable talking to people, it's difficult. I grew up in a home where our house has 60 people. So on any given day,
You said 60.
60, 60.
60. In case you
60.
didn't catch that.
Nigeria will call it face to face, right? Exactly. You have a room with 4 families, there are 8 rooms.
Like a compound house.
Like a compound, so
Yeah,
you're
right.
sitting out. But when I came back every time I come from boarding school, I come back home, I see, I'm like, how did I grow up here? Because when you sit on the balcony downstairs, you see a ton of people just milling in and out. So I'm very comfortable talking to people.
Yeah.
I never had that problem. So in social medicine, we're taught to respect and to listen. What I did not know was that training was actually preparing me for research that will actually be important. I didn't know I'd become a researcher. I now wanted to teach and take care of patients. So you fast forward, I'm a junior faculty, 3rd year out at Columbia, and a colleague of mine said, we've got to do something with the churches. And I said, is that going to get me promoted? I'm on a tenure track.
Right.
I can only work in clinics. She goes, well, that's how it works. There's an ecumenical council of pastors and reverends and priests in Harlem, and they meet in the Office of Minority Health. But so if you take the A train from Harlem, which is where Columbia was, all the way to Brooklyn, it takes an hour. You have to change to the C train. And so I was doing that once a month for a whole year, just listening and watching all the pastors and the council really talking about the needs of their community. Well, I had an agenda. The agenda was hypertension. It was clear at the time, this was 2004, it was clear to us that what we do in clinic in treating Black patients with hypertension wasn't going to cut it. We've got to think about community-based programs. I read up on all the CBPR, all this wonderful stuff, but listening to the pastors talk about what they're interested in, hypertension was not even close. So what they really wanted to know, though, was can you teach about the health effects of violence, fire hazards, or what have you. So I sat there for close to a year. We were writing the grant. They didn't even know about it. But by the time you get to know them well, then you can present your own agenda. And I think is where that intersection happens.
Right.
It then makes it really easy. The Department of Health at the time, led by, I think it was Tom Frieden, the associate was Mary Bassett. We had went to Hustle Mary for some money to do stuff in the church. They were giving home BP monitors in churches. And so that was really what galvanized that. Wow. And the rest is history. My group does a lot of work with communities, but it's got to be that you have to listen, know what they want. And I couldn't agree, more with Lisa that, at least in West Africa, there's a culture and there's a protocol. There are ways to do things. In fact, when I do my work there, they don't even know who I am until I'm asked to speak. But I have a partner who is doing most of the work. My job is just to facilitate. Right. Even though I'm Nigerian and West African, they don't think I'm from there because my orientation is a little bit different. So I think the idea of respect, listening, and really understanding that people really don't care what I know until they know that I care, right? So it's so very important. That's helped us a lot.
People don't care what I know until they know that I care. So that's a tip to a lesson to walk away with. Thank you so much. So the 3 of the researchers mentioned certain themes, including community matters, respect, and listening. So I'd like to ask our community leaders, your experience with working with researchers. Not all of them listen or respect communities. We're just curious to hear what your experiences have been. It can be positive or negative, but can you share a little bit of that?
So my experience working with Teresa was positive. But there are because Teresa is not always with me in the field because she hired people. And one of the things that I saw is while doing the data collection in the first phase, when you're doing a research with a community, you go out there and she mentioned every community is different and every person is different. Even in the same house, people understand things different. So there are guidelines that people follow, and then when you train a research assistant or someone who's shadowing that, saying, hey, this family you're visiting, the dynamic is this, this, the same thing he say, you need to respect their way of living. So I did find a few of our research assistant people, when they visit the family members, they kind of hesitate to approach, ask a question if they confuse something, or maybe they just don't understand what is happening in the family. For example, in my community, if you go to the house, either the mom will wake up and give you water, or like something. When you go into the door, they give you something to eat, to drink. Some people, they choose to say no. And then in our way of living, it's like if someone come to your house, you welcome them with something. You just take it and then you don't have to drink it, just put it aside. So that's our culture. So when you go visit out and then talking to people, you need to respect their way of living. When you go over there, you need to know the family or the community that you're working with before you start doing something. So what Teresa did was she knew that culturally people that she worked with before kind of the same, and then she learned a few things that she needed to know a lot about the community from us, like the community advisors, and then the members in the community say, okay, we want to do this, how can we do it, how can we approach it? So I would say it was the whole thing that we worked with was positive. We came together, brainstorm, we say, how can we do this? We talked to the other community leaders, this is how we approach. So it was positive.
Thank you for sharing those remarks. Reverend Hickman.
I have to say my research partnerships have been positive. And they've been positive.
Thank goodness.
They've been positive because of knowing how to ask questions, making certain that you're not doing something someone else wants you to do, but that they are listening to what you need for them to understand, to make certain that you have the resources and you have the education and you have, I'm big on marketing, because if you do not educate a community before you go out to request of them, you will get a closed door. And so I have to, give major kudos to Dr. Cooper. She listens at community advisory board meetings. She takes the comments from community seriously, and that she brings on the best people. Her team is exemplary. I'm not patronizing you in any way, shape, or form, but she has the heart. And as you said, you always feel like you go to church. So church says that Paul was the one that was exemplary. He never went anywhere as a missionary and just jumped in and told people, this is what you need to do and how you need to do it. But he observed, he listened, and he worked alongside. And I think unless you can do those things with the people that you're hiring from community, agencies that you want to work with, it will always fail, it will fall flat. And he left them with something. I know for sure that if funding dries up in any aspect of any of the works that we do, that Lisa is always, every single day, looking for funding to keep things going. So have other providers that we have worked with, because I never believed that you could come into our community, get what you want, and then leave a dry hole. And that is something that every researcher should take into consideration. You have to have sustainability built in at the end. And you also need to make certain that you have well informed the community agencies that you're working with on what it is that you do and how you do it and why you do it.
Thank you, Reverend Hickman. So Dr. Cooper and Dr. Ogidebe, your work focuses primarily on addressing non-communicable diseases such as hypertension and diabetes to some extent. Can you share with us your experience with how to tailor some of these interventions to different cultures, different contexts? So both of you are in a unique position where you conduct research in the US, but also conduct research in sub-Saharan Africa. Can you share some lessons about how one might go about the process of tailoring those interventions to different contexts?
Sure. So when I started doing work on hypertension here in the US, or here in, I guess it was mostly Maryland and the mid-Atlantic area, one of the things I noticed out there was that there were a lot of trials that had been done on hypertension treatment, even on like dietary approaches to stop hypertension, the DASH diet. And a lot of them had been done in people who were healthy volunteers who had participated in studies that really they had to follow a very strict protocol, and people had to be really motivated and have a lot of resources. But the work that I was doing really was being done in community health centers and in clinics that didn't have a lot of resources or staffing. Patients who were there getting care they didn't sign up to be in a research study, really. We were doing a research study really where people were getting their regular care. So it wasn't like we could just go in there and then tell people that they had to follow this diet and then expect them to actually do it, or that they were going to be taking this drug or that drug. We had to work with, people where they were, even with the providers in the clinics and the, healthcare administrators. And so one of the things we did was to use results of things like focus groups with patients and their family members to learn more about what some of the common beliefs were around hypertension and what it was and how to treat it, and then adapt those other study materials and approaches so that we were actually using terminology that people could understand. A lot of people didn't really relate to the word hypertension. They called it high blood pressure. People thought, for the most part, that it was something that they could feel. And so, you can't really argue with people and say, no, you can't feel it because you're not, that's subjective. But what we wanted to let people know is that even at times when you feel well, your blood pressure still might be up. So we had to definitely use those kinds of, dispel some of those myths, at the same time listening to what people's beliefs were and trying to incorporate some of that into our messages. So we've done that with hypertension here in the US. And then in Ghana, for example, very well, Yvonne, because you're leading the Adinkra project. We have a mobile health app that we're using there. And we looked at the terminology to describe side effects on there. And some of the words were not words that people use in Ghana. So for example, one of the words I think was lightheadedness. And so we had to change that to like feeling weak and dizzy, Right. Even headache is a word that we use a lot here. We changed it to a pain in my head because people don't refer to headaches in the same way there. So there are things like that you do that I think are applicable in different ways in different settings. So, and some of the things we do here, we also learn there. And I don't know if that's part of another question or not.
It's spot on. And I can actually attest to this because we are in the process of adapting material from the Rich Life study. So we have Katie Dietz in the audience. Hi, Katie. So our Adinkra study team met with the Rich Life team to understand how to adapt some of the materials because it saves us time in terms of developing our own materials, but figuring out ways to culturally adapt interventions or materials that are already developed also helps us to make progress in addressing NCDs in sub-Saharan Africa. So thank you.
Sure.
So I think Lisa has given the textbook answer for tailoring in a way that speaks to the challenges. I'm not going to rehash that. But suffice me to say, every time I hear the word tailoring, I think it's the wrong term. But unfortunately, the way we're funded to do the work we do, we almost have to write these grants in a very linear way, right? And so we'll do what Lisa just said. We'll do it, but we'll write it in the way she said it.
Yes.
It's only now that people are beginning to appreciate that. In 2002, 2003, when this kind of work was at at the beginning stage, it wasn't like that. So when I think about tailoring, I think about two things. So one thing is, you've got to think about, I think the Reverend said it well, you've got to think about knowledge. Do people really have the knowledge about the behavior that you want to have them to engage in? So if they don't have the knowledge, how do you tailor your information to where they're starting from? Of course, you can write them to the grants. People will fund it, right? The second thing, and this is reality, is the issue of motivation. So are they really adequately engaged, really motivated to want to, let's say, reduce their salt intake? And then the third one of that, the third aspect is really the capacity. Do they have the capacity to actually do these things? So we're going to have you engage, increase the uptake of fruits and vegetables, and well, we don't have them in my neighborhood, right? So I can tailor it all I want. If they don't have that, I've got to think about what do they have that can be a substitute to that. So we did a study called CATCH, Counseling African Americans to Control Hypertension. That's, to me, the largest practice-based trial, systems level hypertension controlling blacks in the country, period. 1,000 patients, 36 health centers, they all FQHCs. And we said, we're going to train nurses to deliver lifestyle intervention, as was done in Premier and in DASH. And we're also going to give them home blood pressure monitors to see how well they can engage and improve their self-efficacy in using that blood pressure monitor. And then the third thing we'll do is we're going to counsel them using motivational interviewing. I love that term. To actually engage in how they take their medications. You want to guess what happened? The rate of adoption of each of those behaviors was at best 48%. And we say, okay, so we had a negative trial. And of course I was disappointed. My gray hairs came after that. Driving around New York City, you're everywhere, because we use the textbook approach. And so what happened was the reality, which is the second aspect of tailoring, is what is the reality of people's lives? What is the lived experience? What is the environment? What is the context? So when I see that patient in the clinic, am I seeing that patient with their blood pressure? Am I seeing the context in which they're coming from? So to me, tailoring has to address all of those issues. So of course, in our next study then, we started to think about this. So we went to Ghana and we're looking at, adopting a task shifting strategy for community health officers to actually deliver, identify, counsel, and refer patients to clinic. And what we found very quickly, now we're prosing this, is that the knowledge base wasn't there. So I said, scrap what we said we're going to do in the grant. Let's come back to the basics. Let's meet them where they are. So I think tailoring has to really, in any place at all, has to start from there. Because the context is just different. The capacity, the knowledge, and the motivation, all of that must be addressed when we're thinking about tailoring.
Absolutely. And I would call it adapting instead
Adapting.
of
Tailoring.
Right.
adapting. You adapt.
I was
gonna
just
add.
going to mention that I just learned this morning from Benga that actually community health officers in Ghana are actually what we call community health workers here. Even though we were a little bit confused, we went to Ghana, we had a similar idea that we were going to use community health workers, right? Who would actually help to address some of these issues that people are dealing with at home or in their neighborhoods. And we got there and we were told, oh no, we don't use community health workers. We have community health officers and they are nurses. So we were completely confused. But I just learned from Benga that basically if you really understand the training and the orientation, it's very much the same. So I think that's another interesting thing is just being around long enough and observing and, there was when we heard that, I wanted to just jump up. I was like, don't use community health workers.
They're called community
Health officers. I just had to bite my tongue. I was like, okay, well, tell us more about what the community health officers do and who are they, So I think that was really interesting.
And I also wanted to acknowledge that in the IDINCREST study, the task sharing or task shifting approach that we are proposing to use is informed by your task trial in Ghana. So sometimes when you feel like you're coming up with ideas and they're new and bright, it's likely that someone's already done it, and you have to learn from the best and find ways to enhance existing interventions. So, Dr. Agitabi, you made a point about seeing the patients, but not seeing the environment, the context in which they grew up in. And we know that what happens in childhood has the potential to affect health outcomes positively or negatively long term. So I want to turn to Abdi and Dr. Betancourt and ask you to sort of share your experience in terms of your research with the refugee population here and how that relates to the work you've done in sub-Saharan Africa with children.
Well, actually, this ability to listen, to understand context is where we start. We're very much a mixed methods research shop, and we tend to start with that qualitative piece first to understand from local terminology, local perspective, what are the problems.
Right.
And we're interested in mental health, but we know better that if you just show up, be it in Sierra Leone, Rwanda, or Chelsea, Massachusetts, and say, we're interested in the mental health of children, and then you have an interpreter, they're going to say something akin to, they're interested to madness in children, and you might as well go home. So you have to start with, a more commonly understood idea, like problems. What are the problems of children around here, refugee children around here, or war-affected youth in this setting? I've worked in Rwanda, Uganda, Sierra Leone, doing similar kind of mixed methods. And then we're using very simple qualitative research methods that community partners are trained in. They know the language, so they do a lot of this data collection and help us understand what's appropriate, what are the right terms. So we'll start with, what are the problems of children? And then we are looking through those problems, and you allow all problems to come, right? But we're interested in mental health. We have an interest in promoting mental health in kids and families who've been through loss and trauma. So we're especially looking at the problems related to thinking, feeling, and relationship. And then once we start to get these groupings, we interview further about those groupings till we get local cover terms. And then once we have the local cover terms, we can probe on those with key informants, with adults, with kids themselves. And then you're in a very different place for talking about mental health. You're not, mental health is often stigmatized. Although a lot of these disorders occur in adolescence and young adulthood, they have a high burden in terms of when you look at disability-adjusted life years or how they impair daily functioning. People who live with mental disorders can't easily thrive in school or a livelihood or entrepreneurship program. So it's important that we get over the stigma and find ways to talk about them. And our free listing results in Somali Bantu Maimai and in Nepali, we had clinicians in the mental health clinic at Mass General Chelsea turning to our tables to talk to their patients, because there you have non-stigmatizing terms and they're indicators for mental health problems when you're trying to talk with families about that. And that's really important for raising awareness with community members about what we're trying to do. We're trying to prevent these kind of problems. And in our formative research, we can also say, so we know that there are challenges when you're coming out of war, you're resettling in a new culture, but some families manage to do okay. What are the things that help kids not develop these problems like asawaladin or other things like that? And what are things we can do with children, with families, with community? So we learn about protective processes too. And then those become the active ingredients for how we take evidence-based models and adapt them to make sure that we're leveraging those active ingredients for protective things we've learned about in the community and in families. So that's my
What about you, Abdi? I'm curious to hear sort of how you've benefited from being involved in research to address adversity in children, being a Somali immigrant yourself. Tell us how you feel like you've benefited from this process.
So from the time we start doing the research, we get a lot of benefit just doing that research, because personally I knew like nothing about my community. Like I was just interacting when someone have like a problem, like they get a letter from somewhere, they came to the office, say, can you help me do this paperwork? But I didn't know what was going on back home.
Wow.
So when we start doing this research, and then we start interacting a lot, and we find, hey, the researchers start finding out a lot of things, like people don't even know the schools, how they work, and then they're getting these papers from their teachers. The parents, they don't know. And then we find the parents are like kind of depending too much of the girls at home, that the girls are not getting the same treatment as the boys. And then there's a lot of things that I can list. So we pick up the things that we can do to help the community. Just we get it through by doing the research. So what we did was nutrition training, and then school system training, and then we talked to the parents about they need to give their freedom for the girls too. So in my community, culturally what they do is girls, they become a mother, have children, have family, that's it. So the parents start applying that principle from back home right in here. So through doing the research, we find the girls are having a hard time going out there experiencing more. And then we say, okay, how can we solve this? So we open a girls group on weekends to say, okay, so let's give them a space so that they can have chat, talk to each other, come up with ideas. Then we bring people to give them a motivational speech. So there's a lot of things that come out through the community that benefited us and personally benefited me, because it teach me a lot of things that I didn't know that I learned through doing this research.
Wow, your remarks remind me of Mrs. Samira Bawumia, the Vice President of Ghana. His wife just gave some remarks about an hour ago during her keynote speech about how to address gender equity, and your comments about some of the perceptions that are brought from Africa. You can take someone out of Africa, but they say you can't take the Africa out of them, and that may apply to different countries. But I want to thank you for the work you're doing to be a voice for your community, and thank you for being here to share your perspective.
Thank you.
So Reverend Hickman. So I recently came across the Baltimore City Community Assessment Report from 2 years ago, and I noticed that you were the co-chair of the committee that created that community assessment, and that was very impressive to me. I think one of the chair was Lena Wen, Dr. Wen. Yes, and so can you share with us how you use your unique voice as a community leader to advocate for resources for women who are affected by HIV, as well as their families? And are there any lessons that you would like to learn from other community leaders globally, or would like to share with other community leaders globally about using your unique voice to advocate for the most vulnerable in the population?
So I started off sharing with you how I could hit a table. and I actually shared at lunch with Nancy how I used to be at City Hall with some of the ACT UP group from, on HIV and AIDS, chain yourself to the door, tell them off, get in their face, don't move, those types of things. And if I'm trying to get a point across and you're saying, that's not going to happen, that's not going to happen. Well, I had a pharmaceutical worker, Carolyn, who told me one day, because this is, Lisa, before I met you, long before I met you, and Deborah probably out here can relate, that I had my hair in so many braids. I had my, what do you call it? My piece on my neck. I was garbed down from head to toe. So they were not hearing me because they were busy admiring the wrong things. And she said, a navy blue suit and some earrings and all. I was like, I'm not trying to be anybody else. I only know how to be Deborah Hickman. And she says, well, as long as you're dancing on the table with your voice up to the ceiling, they're not hearing you. When I brought my voice down, I learned to listen, and I learned to also do something else that the community must gain hold of. Before you sit before the one that you need to ask to make the change and also resource you, you need to know about them. It's a two-way street. And so on that two-way street, you learn diplomacy, you maintain diplomacy. And if you're in a fit of rage, it's time to get up and say, excuse me, and walk out for a moment and get a breath of fresh air. And so in helping, in being the co-chair alongside Dr. Lena Wen, as well as Dr. Axiris Barbeau before her, it was about knowing who were the people that were being invited to the table. And when given the opportunity to also contribute to some people that I thought needed to be at the table, not all of the hospital policymakers and the like, but you need community leaders at the table, and making certain that we had a good blend down to making certain that we had the voices of youth at the table. And looking back at the literature, you want to continuously, do these assessments on community. But I say in the halls of Hopkins is enough assessments for you to sit there and look at from here to oblivion.
Yeah.
And we must stop the foolishness of going out and asking people to give you their life history, and you never go back to us and explain to us what happened. We only got that from Dr. Cooper, who invites community in and the voices that speak for community to, say, this is what happened in our project, in our process, and consistently asking, how do we get more of the people to come into the table? And so in that report that you got, it's a lot of hard work. It's a lot of work in that we still didn't get what we want in terms of not still having some of the people in community assessed, but we had town hall meetings. So I said, you don't want to knock on people's doors, you want to hold listening sessions so that everybody gets to speak. Not just the adults, but the youth get an opportunity to open their mouths and to speak. And to make certain that you have people in the room that can actually codify what is being said, not the way that you want to hear it, but the way that it's being told to you. And that way there's an equal benefit. Both glean and learn from each other. Both find that you really are caring about me, and it's time to do something about what is taking place. It is sad still to see in Baltimore City that African Americans' life, their longevity is still only at about 40% compared to whites. And so there's something to be said about that when we talk about cardiovascular issues and all of these things. And what leads to that is that we continue to have inequity in housing. We continue to have inequity in the jobs that people hire for. If I'm a different color, I get a different wage. But I don't know that unless somebody else tells me. And I have to do, again, my research to make certain that there's going to be equity in the pay scale, there's going to be equity in the housing situation, which our housing in Baltimore City is deplorable. You charge $1,100 to $1,500 to have someone rent from you a rat-infested place that has poor electricity and the like, and and you have very little plumbing in the place that you're charging for. So these types of things make a difference when we're talking about doing research, when we're talking about adapting the process. People have so many things on their minds about surviving so that they can strive, so that they can thrive, that when you and I show up, they're wondering, what do you have for me? Well, you should have some incentive that helps them to do these things. And if you don't, then those are the things that you get. So in helping to put that report together, it was looking at the reality of the situations and how are we going to go about changing them, and making certain that you had all of the department heads from Baltimore City come to the table. That's the other flaw, that no matter where we are, whether we are local or global, we will have to have the political avenues addressed. And trust me, those are some major challenges, because what happens here is not the same as what's going to happen in Ghana, what's going to happen in Uganda, or in Nigeria, or any of those other places. In some places, they hold you to the codified system that you were born poor. No matter if you get an education or not, they're still looking at you as poor.
Wow. Thank you, Reverend Hickman. And you mentioned challenges. So for all our panelists today, I'm sure you experienced numerous challenges, from grants that are not reviewed or rejected and papers that are rejected. And for community leaders, outcomes that you don't observe. And you spend hours and a lot of effort on those endeavors. So I'm just curious to know sort of what feeds your passion, right? This is obviously hard work and they make it look very easy, but what keeps you going in terms of your work to address health equity locally and globally? And I'll start with you, Abdi.
Yeah, so when I first came in United States, I saw how my community is struggling. And when I was in the refugee camp, I saw how my family and the other refugees are struggling. And personally, I find it like just giving 1 hour of my time helping someone else who is in need, that makes me happy. You know, and then even if I don't have, like, if someone needs food and I can get that person the food, but if I can tell him where to get that food, that's a help for that person. So those are the things that drive me. Like every day I say, you know what, today I want to give 2 minutes or 1 hour of my time to help someone I can help. I don't have to pay $1,000. I just have to at least tell someone that need information. Those are the things that drive me every day to help our people. My community, they always need something. There's always someone in the community need help. The help it's not like they are sufficient, they don't need anything. Because when you live in this neighborhood, there's always someone who is struggling. I was telling Amalia just, sometimes if you attend events and you see the programs that they're showing, all those programs are there to help or support someone that needs in that community. Those are the things that I see. It's like when I go out or in the community or in the office, I want to give up time, 24 hours. I want to give those 24 hours to at least 1 or 2 hours to help someone who needs my help. That's what drives me.
Thank you so much, Dr. Betancourt.
So the first part is it's an honor to work with people like Abdi. That keeps me going all the time. And I think, you know, coming from a very low resource setting, working in places like Sierra Leone or Rwanda, working with refugee populations in the United States, when you can contribute just a small thing of quality, you can see an impact. And that is so satisfying. To uphold ethical standards, quality, do your highest quality work, to just see if you can move the needle just a little bit, you know. And so after all this collaborative work and understanding context, understanding, being able to listen, use language that's not stigmatizing, we designed a family strengthening intervention that's done by refugees for refugees through home visiting. And so, you know, we've been very much thinking about what's the pathway for making this affordable, possibly prevention services done by licensed community health workers. We have those kind of policies emerging in Massachusetts. That's very exciting to move it from the early idea of we've got to do something to help these families thrive early to then co-developing a model, then testing it for feasibility, piloting it, seeing that it can be done, and we can move that needle a little bit, and then to move into like, is this really effective? Do we get like the impact we want to see scientifically? And then beyond that, you can't just stop at that trial. You have to think about implementation science issues. You know, if you've been deployment focused from the beginning and you're thinking about the pathway to sustainment and keeping quality, that's a very challenging part, but it's a critical part. You can't just stop at the randomized control trial. That you want to think about what are the pathways to now have this reach people, to have it sustained, to think about, you know, what's the workforce, the quality sort of stuff. And that is just such an exciting topic to get to work on. Very, very challenging. You have to do it in partnership, but it feels like a real honor to be a part of those sorts of teams trying to crack those sorts of challenges.
Thank you. Dr. Cooper.
So I resonate a lot with what Abdi and Teresa have said. I think I always thought what would really be rewarding to me is that, you know, I would have a successful outcome of one of my studies. It would show a major like effect and it would be statistically significant, you know, and then maybe the policymakers would like pay attention to it and they would pay for it, and then, you know, and I think that is still obviously one of the things that I hope will happen. But I think it's really the day-to-day interactions with people that really make this worthwhile. I think about interacting with a patient who, you know, one of the patients in our study who didn't have a bed to sleep on. And basically making sure that the community health worker was able to get beds for her and her children to sleep on. They were sleeping on the floor. It's people who feel like they've lost hope, they're suicidal. No one, they've gone to get help or health care, but no one's really listened to them. And the fact that we've been able to provide that to them. It's things like people on the community advisory board who feel like, I'm getting emotional, choked up here, but who feel like no one's listened to them, like they don't have a voice. They have problems that they've been suffering with for years. They've been discriminated against, they've been ignored. And or people have come and done research on them and not told them what they found, and gone on and got more grants or whatever, and they're left with nothing. They don't have a program. The fact that people can see that we care, that we value them, we respect them, we listen to them, that's rewarding to me. And they actually give back much more than I give, because I've had community advisory board members bring me cakes on the day that I got my grant rejected, or, I've had letters come from patients to say, how much their lives have been changed by something that I did. And so I think it's those day-to-day things that they seem small, but I think they are the main things, and they are the things that, over time, hopefully that story will actually lead to that person growing and becoming stronger and becoming a voice for their community. Those are the kinds of things that feed my soul. So
Thank you. Thank you for sharing that.
Wow, this is deep.
I'm going to drink to that.
I know.
This is very deep. But to go back to your question, I use a saying that so Chinua Achebe was a Nigerian writer, and he said in one of the books that he wrote, I can't remember if it's Things Fall Apart or No Longer At Ease, that you don't enter your house through another man's gate. So the idea is that if I enter my house through the gates of your house, I would have co-opted the metrics with which you look at life. And then I enter my house and I'm using metrics that you have, not my metrics. So what are the challenges? I find these things, maybe it's old age, maybe I'm getting older in this thing. I find these things a bit, I don't like to use those terms. I would say it's a journey. So to me, it's almost like, what is glamorous about health equity research are the results that we share. But the journey itself is what is rewarding. So in other words, people see my glory, but they don't know my story, right? Somebody said that somewhere.
Yeah.
So to me, it's more like I'm blessed. I'm fortunate to be doing work on my own terms. I'm doing work that I think is my purpose. And I'm getting paid a ton of money to do it, right? So in other words,
You're getting paid a ton. I never heard that.
because it's supposed to be free, right? So anytime you
And
get
he's being
paid,
honest. Yeah.
anytime you get paid for something that is free, that's a ton. I'm doing this for me. Now, when you pay me to do it, and then you give me the accolades for doing something that I think I should be doing, so it's not a challenge. Yeah, for every one grant, I probably written 10 that didn't get funded. I didn't have the cakes that they can bring to me. I just don't have the time. I just don't go back and write the next grant again. Right? But so the point is that, we've got to figure out a way to start looking at what are the metrics with which we look at these things. Is it the metrics of how we look at things, and we call it challenges? Or is it the metrics of the story? That how did this became policy? But the moment it becomes policy, does Teresa stop doing that work? No. Right? You probably won't.
No.
Even if you get those things adopted, you probably won't stop. Because there's something inherently important about having a mission. So to me, health equity research is not for the faint at heart. I told Lisa this before. It's a long journey, requires perseverance, grit, and then a lot of patience. Because if you're not patient, it's difficult to do this stuff. So I'll tell you a story. So I showed up in Ghana. My colleagues from NYU was meant to be a fact-finding mission where we're meeting with the Ministry of Health, the teaching hospital, to see how we can create an MOU, right? Around, School of Medicine, School of Public Health there, do something around research. And I went back to my hotel room and I was in tears. I was in tears because I realized that I was the only African with the group, and that the people that I came with were actually more passionate about the work. But then what I saw was people were looking to us to make a difference. And I'm like, wow. Now my tenure is hanging. Those are the metrics, right?
Yes.
On the kind of work I do domestically. But the moment I got back, I knew I had to do this. And regardless of the tenure, we had to just continue to write the grants to do work in Ghana. And I still go to the hotel room crying because when I bring 20 professors from here to Ghana 3 times a year to teach research on something that doesn't, the metrics for tenure doesn't look at those stuff, right? And every night you go back to your hotel room, you think about whose life you've changed in terms of telling people they can do it. That's powerful. So I don't know if I can call it challenges. I can only call it something that's really, very rewarding. I think it's a work that's rewarding. If it's not a mission for you, then it becomes a challenge. Wow. And if it's a challenge, then people say, you know what, I shouldn't be doing that stuff. Wow. So find your passion. Yeah. Figure out what it is and get paid a ton of money.
Reverend.
Well, I found my passion, and I have not gotten a ton of money.
Yes.
For 28 years, Sisters Together and Reaching has grown, but it's not because we have a ton of money. We have a ton of struggle, and the struggle is so worthwhile to be able to see that over 28 years, we've seen over 100,000 persons in the Baltimore eligible metropolitan area. That means that Baltimore City plus 7 other counties in the state of Maryland that we have worked with, us as well as going as far north as up to New York and far south as North Carolina with our services. And so what brings me passion, what brings me the love and the constant desire is I get to laugh every single day. Community is phenomenal. Even when they're going through their most difficult times, they bring you joy and they keep you real with real life situations. And what we can open unto them is a group of people that hail from the communities that they also come from, and show them every day, you can stand up. You can stand up. You will stand up. You are standing up. And to be able to look across this city and also across this nation and know that we have touched women's lives that are now in phenomenal positions as executive directors and other HIV organizations, and also standing up their organizations, or that we have touched women who actually have hypertension and the like, and know how to monitor their blood pressure and are losing weight and doing things and moving. Those are the things that bring me passion. Working with people that used to be patients and they are still going out and reaching, but we can open up our resource manual and find what you need for your children, find what you need to find housing, find what you need to be able to get into a GED class or to get into a computer class or anything that's going to continuously help build you up. And that for 14 of those 28 years, we have been doing a one-day conference called Why Women Cry. And they made me cry a lot when I got home on Monday. We had over 2,000 women to come to that conference free of charge. We have kept it free so that they could get what they need from providers that are here, from providers that come from other places, from the Chittima eBays of the world, and like my whole team of daughters sitting over there, that, and I got a whole team of some men around here, and I got people's husbands that I claim and the like. I have a great time doing my job. So my abundance, is in the fact that life just gets richer, and that the Lisa Coopers of the world are for real. They are phenomenal, and that they care. That they are doctors that actually care. There are people that would not sit with a lot of us from community but they're sitting with us, they're listening to us, and they're helping to grow up. So thereby, my degree is not in research. It is not in nursing outside of my licensed practical nursing degree that I got graduating out of the 12th grade, but it is in divinity because I believe that there is a God that I choose to find my purpose in each and every day. And if you don't know what your purpose is, you will never find your passion and you will never enjoy what you have to do when you have to go out to the least of them.
Wow. Thank you so much. I feel like
Can I say something? I think we don't talk enough about this. So when we talk about health equity research, often enough, what we talk about is, we talk a lot about the deficit model. It's about what we don't have. But we really think about it as the Reverend was saying, you know, you stand up, you're standing up, you will stand up. That's resilience, right? So think about it. If it is true that all of these ills that we have, right, that shows us the inequity that we're talking about. If the effect of these ills are that linear, certain populations will be wiped out today, right? Think about that for a second. Talk about Liberia, right? Shortage of healthcare workers. But you go there and you see people, and they're thriving, and they're smiling. Rohingya, talk about the community in Baltimore. I can go on and on.
Right.
People will still say hello to you, hug you, happy to give you something. I think when we talk about health equity research, we've got to come to the level where we have to develop models that can actually anchor those resilience factors. And then that should become the target of our interventions. We need to stop looking at the negatives. And it's, you know, that's why I hate saying the words weak healthcare system. I was delivered at home in 1962, right? By a domiciliary nurse. That's what my mom would call it. And it was right there in the living room, right? So when you think about this stuff, but I'm still here, right? So we've got to figure out a way to start talking about resilience. You talk about the African American community in this country. It's all resilience, right? Have we studied that? Have we leveraged that? Have we packaged it? Have we put that into interventions in how we deal with, you know, the inequities? So again, just to make this much more positive than
Resilience. Thank you. And I know I've spent a great deal amount of time asking questions, and at this point I'd like to turn it over to you, the audience, to see if you have any burning questions that you want to ask our panelists for today. Yes,
I don't
please.
have a question.
Or a
I have
comment.
A comment.
Yes.
And I just want to thank all of you for the powerful work that you're doing. And I attended Why Women Thrive.
Yes.
This was my first time. And ditto, kudos to you. You have been an inspiration to me because I'm having my challenges with dealing with disparities. I chair the CAG, the Community Advisory Group for the Center Against Cancer Disparities. And one of the things that I've been dealing with is the politics of medicine, racism, and all of this. And you have been a great inspiration. And to you, Lisa Cooper, I was inspired by you on TED Talks.
I paid all these people.
But all of you today have been an inspiration for me to stand in integrity with my own belief about health disparities, and I have a story behind that. I'm not going to get into it, but I just want to say thank you all for the greater works that you're doing. And spirituality plays a big part in health disparities, and I want to maybe have a conversation with you later about that. But you've all been a great inspiration. Continue to do the work, and blessings to all of you.
Thank you.
Thank you. Any other comments, questions, please?
Hi, my name is Shadow Woodgage. I'm a senior public health major at Hopkins. Dr. Cooper, you mentioned earlier that you utilize a mobile health app in one of your interventions. And I had this question to you and also to the panel. In terms of digital health communication technologies, how have you seen that impact community-based research and just overall relationship building with the community?
So one of my mentees, La Princess Brewer, she's doing a mobile health intervention in partnership with churches in Minnesota. And it was developed, co-developed with members of that community. And it's been extremely well received. It really focuses on the 7 behaviors that you need to change in order to improve your cardiovascular health. It has a lot of motivational messages, including faith-based messages because it's based in the church. It has a platform by which people can sort of share with each other what some of their challenges are or what they've done to overcome the challenges, and has been extremely well received. The pilot study showed remarkable improvements in cardiovascular risk profiles, things like cholesterol level, blood pressure, and even weight. So that has gone really well. We haven't tested our intervention, our mobile health intervention in Ghana yet, but one of the reasons we're using it is because, it really helps to overcome a lot of the barriers that people have. People there in Ghana at the clinics where we're working, they live really far away. And there's also a lot of traffic in Kumasi.
Yeah.
And there's a long waiting time when people go in to see their doctors. And so one way that this app helps is that people can record their blood pressures into the app. They can send it to the community health officer, and then that person can confer with the doctor and help them to adjust their medications or do whatever they need to do without them having to come all the way into the hospital. And so many people have phones, smartphones now, and all those kinds of things. So we're really looking to see if that's a way to help to address some of the health professional shortages and the access issues. And whatever we learn from there, we're going to bring back, here and try again, because we know that, again, everyone's using cell phones. My mother's 89, and I can tell you, she's a texting queen, like posting pictures on Facebook and everything. So
the one caveat though is this: there's a ton of data. I agree. In fact, a colleague of ours, a visiting person at NYU, Karen Yates, just won an award with WHO where they're using iPhone with an app to actually take digital photos that will replicate cervical screening, cervical cancer screening. And so you upload the images, because you're in a rural area in Tanzania, that's where she did that work. You can't make it to clinic. Even if you do, the specialist doesn't come until once a month. So they will upload all that data, right, to a central place where you have a gynecologist sitting in their office somewhere, interpret that data. The predictive ability of that is pretty strong. The key thing we have to be worried about is that what I often hear is that, digital health or mHealth is almost like a panacea for everything. Again, if it doesn't address knowledge, motivation, and capacity, it's difficult to know what it means. You've got to define what the value is that you're adding. But it helps, all the structural barriers all of a sudden poof.
right. It's a tool.
It's a tool.
It's not a solution in and of itself, right?
Yeah, and I would agree with that. In Rwanda, we're developing digital supports for our community health workers who do home visiting. We just had a collaboration with one of the design classes at Boston College, led by our Vice Provost, Sunan Bhattacharya, for design and innovation, where he invited Abdi Ali, some of our team members, to come in and meet with 30 BC undergrads about design challenges that make carrying out the family strengthening intervention for refugees by refugees challenging. And then to throw those challenges out to 30 students who are studying design and think about, well, how would they crack it? What would they do? What are their innovations? And then to have sort of a user experience focus, like, the human-centered design principles, I think are really important when we start to think about working with communities, listening deeply, understanding. And so, as I agree with you all that it's not the silver bullet or the panacea, but I think when we start to really think about the end user and user-centered design and improve, like right now we have paper-based manuals, but there could be ways in which more digital supports, tablets, embedded videos could help us swap quickly between cultures, could help us have some of our vignettes we have in the manual, some are kind of Nepali, some are Somali Bantu. We could easily use technology to make that even more smooth. So I think there's a lot of potential for it if we do it with the human-centered design sort of orientation.
Okay. Thank
So,
you.
and I would just say to you that I'm probably in the middle of that. I think it's good to have electronic medical records to make sure your data can flow to wherever it is that you're receiving your care. But it's something about human touch that does something that no digital device could ever do. And also, I have to say, I'm a skeptic when it comes to when the cloud is going to burst. And when are the clones going to come out of the closet? And I'm walking down the street and someone says, I just saw you back there. I'm like, you didn't just see me. So those are my kind of quirky things. They might, well, they're not quirky to me. I'm serious about it. I'm serious about it. And he's back there with that very tie on, your orange keychain on. And I'm just like, it's a scary time. And I think the more and more technology we develop, the crazier people get.
Right.
And we lose something. We lose our, humanity, our humanness. It is nothing like being able to give someone a hug, to hold their hand, to help walk them through. Those types of things. That's what causes what we do to work, is that we can be with each other.
Right.
We can be with each other.
And with that, I'd like to say thank you so much. I know we're.
Thank you so much.
Thank you so much to our panelists for being here. Before you take off, I had one housekeeping item that I omitted to address, and which is to thank our co-sponsors. So the Bloomberg American Health Initiative co-sponsored this event, as well as the Johns Hopkins Alliance for a Healthier World. I'd like to thank our panelists for traveling from Boston and from New York. And I'd like to thank you for making time to be with us today. But we'd like to offer you some refreshments outside. And in most African cultures, when you visit someone, they offer you a drink before. We're doing things differently. We are going to offer you something, a drink after. So thank you for being here and enjoy the rest of your afternoon.
Thank you.